Good morning, buenos dias, bonjour. Today we're going to talk about quality, and this afternoon I'll be talking more about patient safety. So because of the limited time, we'll start with quality this morning. So I have some questions for you, especially those of you in the hospital realm. Do you have an ethical responsibility to give good patient care to every patient that comes to your hospital? Second question, is your community better off since your hospital isn't there? Okay, so let's ask some questions then. What portions of your patients, what quantity of your patients are actually receiving evidence-based medicine? Have you ever thought about that? Secondly, how does your healthcare provide need to change so that I will wait for 2 minutes, almost a star. Somebody want to sing for 2 minutes? Well, for 2 minutes, I'll tell you folks here that I may be coming from Loma Linda, but I'm sort of a child of Inter-American Division. I've spent almost 11 years of my life in this division. I was growing up in Bella Vista as a child, going to primary school, and Dr. Carpintero, one of my former students. I was in Morelos for 7, almost 8 years. So I'm at home here. And I can keep blathering until we get the 2 minutes over if necessary. Ready? You want me to start over? We will start again. So the first question to ask today is, do you have an ethical responsibility to provide consistently good healthcare to every patient? Is your community better off because your hospital is in that community? So let's ask some questions. What portion of your patients are actually getting evidence-based medicine? Secondly, have you looked at, where's the difference between evidence-based medicine that you know is to be there and what you're actually giving? And most importantly, do your healthcare professionals have the skills and the support to make these changes so that you're providing the best care everywhere? So which of these is most dangerous? You're going to go rock climbing, go down any ropes? You do bungee jumping? Linda, you like to do bungee jumping? Or are you a patient in ICU? Think about that. Well, you notice, look across on this diagram on the right here, nuclear power is very, very safe. And if you, like me, you came in an airplane, it's pretty safe. And you come over here way off to the left, there's bungee jumping, and maybe 1 in 100, or mountain climbing, not very. Well, where does healthcare land in all of this? It's not the safest place to be. We'd rather be at home than in the hospital, right? So you can say, look, on my hospital, we're doing 80%, maybe 90%, we're doing what we're supposed to be doing. So I have a simple question. How many of you got here by flying in an airplane? Quite a few. So let's say your airplane has an 80% chance of doing the right thing, and you're flying from San Jose over to Kingston, for example. And the pilot says, it's a beautiful day. We're going to get there really fine in 2 hours. And we have an 80% chance of getting there. And this comes every day. And this is my 5th day. We'll see if we get there. Are you going to get on that plane? No, then why should you have a hospital that only does 80% of what it's supposed to be doing? All right. So from an individual patient, you either get the right care or you don't. A hospital should be looking reliable care to every single patient. So it's an all or none for those patients. So a hospital is a system. Dr. Deming taught us a long time ago, a bad system, the system is designed badly, poorly, will defeat the good employee who tries to do something good in it. And the other part is, Dr. Batalden told us that every system is perfectly designed to get the results to get. If you measure your results, you look at your hospital and you say, well, it takes 3 months to get that patient into this, or the operating room is always 3 months behind, or always delaying. And you look back 3 months ago and you have the very same results. And you look at this right now, in 3 months, unless you change your system, you're going to have the very same result. What the results you're getting is depending on how your system has been designed and how you put together your policies and procedures. So in 1999, the Institute of Medicine wrote a book called To Err is Human. It showed us that there's a lot of things we've got to do to improve healthcare. And then they came back 2 years later with a book called Crossing the Quality Chasm. It showed us how to make these changes. That's when the quality program really got started moving. So my question for you, do you want to change your system? It's not necessary because survival is not mandatory. If you don't change, you may become irrelevant, all right? So we don't like the current level of performance. We have to change or stay frustrated. And I'm here to say we want to change and improve our systems. So here we go, crossing the quality chasm. This one's a little strange. I know you're over here, you think, oh, we're doing really good. And then you look over to evidence-based medicine, there's a gulf. There's this big chasm between where we had to do it. So how do we breach that? How do we cross that chasm? And that's what we're going to talk about is quality improvement. We take that and fix it so you can get from one part to the other. Now, have anybody ever jumped from one part of a cliff to another? Have you ever done it in 2 steps or just one? So have you ever jumped across a chasm in 2 steps? No. So we need some help in how to make do this one. And that's what we're going to be talking about. So quality can be defined in 6 different areas. Number 1, it's safe. If you're at home, it's safe. When you come to the hospital, you should be just as safe. Number 2, is the hospital effective? Are you doing evidence-based medicine? Are you providing ineffective care, something that doesn't work? Maybe too much of something or not doing something you're supposed to be doing. Thirdly, is it patient-centered? That is to say, patients have the decision power. They know what's going on. You give them the information. Fourthly, it's called timeliness, but I like to call it access. The patients, can they get to you? Can they get to the different parts of the hospital they need to? Do your staff have timeliness, or is your system so bad that it wastes time trying to find things? Number 5, efficiency. Is your hospital efficient? Is it working well? We want to get rid of waste in the system. And number 6, equity. You treat every person, no matter what their background is, properly every time. So, are our current hospital systems working well? Well, Dr. Berwick, who is probably the most famous person today in quality, taught us that we must accept that human error is inevitable. And we have to design around that fact. We have to design our systems to take, in fact, that we are human. If you try to get to 0 errors, it could be failure. So, if you want a much better performance in your hospital, what do you have to do? You have to change your system. You have to have a new system. And remember, change means that you're doing something. Improving means you're changing. But not all change is improvement. But all improvement has to start with a change. So the starting point for quality is to recognize that your system, the way you've designed your system, is very, very important. Remember, every system is perfectly designed to get the results that you're getting. So we don't want to make our staff to work harder. We want the staff to work smarter. We have to redesign the policies, the procedures, the way we do things to do things better. So again, key message to you folks, if you want to improve how your system works, how your hospital is efficient, you have to change how you do your system. So there's 7 laws we're going to talk about in doing quality. Number 1, that was first law. I'm sorry. Yeah. Number 2 is be transparent. If you're doing a scientific experiment and it doesn't work, you don't go cry and go away. You learn from that, right? So we open the failed test. If it doesn't work, acknowledge it. Go ahead and learn from that. But we don't always like to do that. Number 3 is attitude. What is your attitude as you approach these things? Well, excuse me. Do you want to be humble? Do you want to learn? Do you want to be a disciple, teachable? No, we don't. We want to be the teacher. We want to be the head of everything. We don't want to have to take this ability to us humbly learning. We don't like feeling stupid, if you wish it that way. We'd rather be the teacher, one with the answers. But no, we have to be humble as we learn how to change our system and be transparent that way. We have to have a willingness to fail with the changing of things. Number 4, do we have agility? For example, you read in Lancet that came out yesterday and you follow some new process, new ways to do things. Are you going to do anything about it? Or this meeting this week, you're here learning how to do some things differently. And you say, oh, I wrote down 4 or 5 great ideas. And you got back to the hospital and, there's problems. You got to face them. You got to work on them. And next thing you know, 3 months have gone by. Oh, I was got to start working on some of those problems, wasn't I? So to be agility, my message to you is, what can I do by next Tuesday? So after you leave your meeting, write down, by next week, start on the changes you want to get going to make sure you're doing what you want to do. So agility in making change is super important. Number 5, quality improvement is team-based. Now, what I have is a word in English for team, but I think we can Spanish where they've worked on it away. So if T stands for together, we're an integrated system. E, everybody. A, achieves more. If we work together, we're going to achieve a lot more together. But that means also all the employees in the hospital, we work together for a common mission, common idea. We're going to be doing so. But then you say, I'm just one person. I can't do very much. But what does that mean? That means they're right. That's why we do it quality in teams. We don't just have one person responsible for all these things. We put this together, we work together, and then we're able to achieve a lot more. Sixth law is measurement. No, we're not going to give you higher math. We're not going to give you calculus. We just want simple measurement. It's the key to improvement. Some people say what gets measured gets done. It's not quite that all true, but there's very lot of truth to that. So an improvement means we collect data, and then we, for example, the waiting time to get to see to a doctor or something, we want to improve it. We want to fix that. And the seventh law, there's many different ways we can do quality. There's lots of different methodologies. So the first one is the method of improvement, and we're going to talk about that today. Second one is this interesting thing called lean thinking, not somebody's thin, but this, for some reason, it's lean. It works on getting rid of waste. We're going to talk both of these. You may have heard of Six Sigma. There's queuing theory. There's the theory of constraint. There's the ISO. If you have a laboratory, it's a good way to make sure your lab's working well. In North America, there's the Baldrige criteria. There's FEMA. There's all kinds of different systems. Learn, accept one system at minimum, and you make your hospital proficient in that one. Today, we'll talk about method of improvement, a little bit about lean thinking. Those are the ones I would have you start because they're really easy to get going. The method of improvement is really very simple, but it's very profound. Okay? It asks three questions. First question is, what are we trying to accomplish? That is, what is your aim? If you want to change something, what specifically do you want to change? Second question is, how do we know if we put this change in, it's going to be an improvement? Is it a change? Is it better? That is, we're going to do some measurement. And thirdly, what things can we do in our system to change it so that we make it better? You have to sit back down and start some thinking. The team members can say, if we try this, we try that, come up with 3 or 4 different ideas, and we'll check them through them one by one. Then we do this, what's called the PDSA cycle, the plan, do, study, and act. And we'll talk about that here in a second. You want to test those ideas. You're going to do a scientific experiment. So the PDSA cycle, part of the method of improvement, it really is the scientific method. In the planning part, we start by getting a baseline measurement, what's going on in that system. How many hours or how many minutes maybe does it take the lab to do this test? You measure it, you know what it is. And then you analyze the step, and we'll go into detail later if necessary. Second one, you try a new change. You say, well, if we do this differently, let's see what happens. You've planned it, you put one of the changes into practice, you try it for 2 weeks, 3 weeks, 4 weeks or so. Then you measure it again, you study it, you check again. If it used to take 2 hours to do it and our new change makes it 1.5 hours, well, then you're going now to the analysis side. You look at the results of your test. You plan something, you tried it out for 3 or 4 weeks, you remeasured it, then you have 3 A's. If it worked, what do you want to do? You'll adopt it, you'll do it. Or maybe you need to change it slightly, you'll adapt it to what the circumstances. But remember, we want you to be humble, and remember, we're learners. If it didn't work, what are we going to do? We're going to continue doing it? No, we're going to abandon it. You have to stop and think. This is all good thinking ways for you. And we'll repeat these PDSA cycles till we improve that different process. So I do want to, we could spend a long time explaining all this, but I want to put a good emphasis on the aim, what you're wanting to be doing. In English, we use the word SMART and use each of the different letters there. Your aim must be very specific. It must be measurable, something you can measure. It must be something you can actually do. It must be reliable. That is, you do it over and over again, you get the good results. And it's something timely. So your aim should be a statement saying, I'm going to take the time from a patient needs to be admitted from the emergency room up to bed, not 4 hours what it's now. I'm going to specifically move it down to 2 hours, and I'll do this between now and November 1. You have a specific aim. And this attainable one is very, very important. You may have this huge problem. It's good, important to break it down into small little segments, working them one by one. I used to think we'd say people taking too big of an aim would say, oh, you're trying to solve world peace. But I think a better one to say is, you're trying to boil the ocean. Would that be easy? No. So you don't want to take all of it at once. Break it down into individual little parts and work on each one by one through these PDSA cycles to get that part of that process working better. And that aim should be very ambitious. A stretch goal makes you work hard at it. Don't just say, oh, right now we got 10% of the patients doing this. Let's get up to 14%. No, why don't you try to get up to 40 or 60 or 70? Get your aim to really make you have to work too hard to do something. All right. So a bit measurements. Let's talk just a second again. If you've never had a metric, this is a little harder perhaps in the church system in a way, but in the hospitals, we never have a metric. You've never been held accountable. If you're supposed to be doing something by a certain amount of time, then you're being held accountable. Some people say the idea is what you get, what you reward. If you've done it, you get things happening right with you. But important renewing with measurement, you can spend a lot of money on some fancy software or fancy statistical programs, but you want just enough measurement to know whether that change made a difference. Many times it's nothing more than a sheet of paper and pen and pencil. And writing now, it took me today 10 minutes, now 9 minutes. That's very small amount of time. Don't spend the time being fancy with your measurement. Do just enough measurement so that you know whether that improvement actually is happening or not. Okay, that was a little bit introduction to method of improvement. Lean thinking came from Japan back in the 1950s when they learned how to take industry and make it a lot more productive. And so one of the ways to look at lean thinking is these 7 different ideas. You start with the word gemba. That's a Japanese word. I don't expect you to know what gemba means, but gemba means if you have a problem in your laboratory, you don't take a team to work on decide what's doing and you go into the executive conference room and say, well, what do we do here? Well, I think they have this problem. I have that problem. No, you go to where the problem is. You start by interviewing, talking to the people in that area to say, what are the issues? What's going on to know really what is happening? Remember, we're working in continuous improvement. Then you can have some people call it the 5 whys, the 7 whys. And you say, oh, why is this problem happening? And they give you an answer. Well, why is that happening? They give you an answer. You just keep asking why, like a rascally 2 or 3-year-old, why are you doing this? Why are you doing that? You're keeping on back and back and back. You get down to really what the cause was. And you may find that cause was 30 years ago, somebody did it that way, and we've been doing it ever since that way. Figure out a much better way to do these things. The next one is to developing an eye for waste. That is to say, when I go into your hospital, I've never been there before. He knows what I've done this. You have some fresh eyes. Say, why is that way? And the point is, if you see something every day in your hospital, that's normal. That's just the way it is. If you bring someone else with, quote, fresh eyes, they look at it and say, why are you doing that? You're wasting your time. Well, that's really a problem. Why aren't you paying attention to it? So bringing somebody outside that department in to look at it brings lots of value. Later we can talk about process mapping, help you figure out how that process works. And then there's these 5 S's. This one is really fascinating, and I'll show you some examples, but I think you need examples. 5S means you go to an area that's in a mess. It's all mixed up. So you sort all the items there. You simplify it. You put them all in order so it looks good. Make it clean. You sweep. You sign it. You standardize so you know exactly where various different things. And I'll show you some examples in a second. And then you make it part of your system. You change a mess, a chaos in an area, and you fix it. Now, nurses, I don't think we have any nurses here hardly, do we? Nurses are very, very well known to know that if you're missing certain items are very hard to find, they have a little stash hidden away if they need that suddenly, right? So the 5S does not mean you scrounge, steal, stash, scramble, or search for them. You don't want to waste your employees' time doing this. You get it fixed. So let me show you visual examples. Here we go. This is in the operating room. This is the anesthesiologist tray. And you see there's syringes and there are all kinds of things there. And Is the anesthesiologist important in the OR? And if the patient's unconscious and you're doing this and the blood pressure starts falling up quickly and you need to do something quickly and you say, oh, I had some medicine all for them, and it may take you 30 seconds or 60 seconds or so to find which of these actually is the problem that we could help you. So if you 5S that problem, you make it look like this. You take a sheet of paper and you have items you don't know always there. You have the syringe with this one, that, and there. All the items ready known. You see it really quickly. And if a problem happens, instead of 60 seconds, you might find 3 seconds, so you can start improving the life of that patient at that point. 5Sing means you make the default easier to and for the employees to work and see how it does. Let me give you another example. Come on, here we go. Here is the utility room for a hospital. Do you know what's in there? Kind of hard to tell what's in there, don't you? And if you send the nurse to go looking for it, it may take her 30 minutes to find something. Well, if you 5S it, you change it to where everything has a specific place. And then you see if it has electricity, you have it plugged in. It's all ready to go. This hospital did it. They decided they needed $20,000 for more equipment because they couldn't find any. When they fixed, they 5S their problem, they didn't need to spend the money because they found that all the stuff was where it was supposed to be. Does your maintenance problem ever have a place where you can't find anything there? Well, 5S it too, make it know exactly where it's quickly for the employees to find what's going on. I see some smiles that people say, I've seen that before, right? All right. So lean is a way to problem solve. One of the ways we do that is something called an A3. An A3 is a project management system that can work for anybody and any way of doing things. We're talking about hospitals, so it could be a clinical issue, but the administration side can use an A3 just as well. And I won't go through the boxes, but this A3 has 9 boxes. It's a way to coordinate and run and how you make a project. It can be administrative, clinical, or both administrative and clinical. And the whole point of the A3, it works on a system. And when you get through, it tells you a story. So here is a story from Suiyuan Hospital, Adventist Hospital in Hong Kong. They decided they would change the light bulbs in one of their patient towers. They saved over 6 months, $150,000 in electricity cost by changing their administrative system, change the LED lights. It was a beautiful administrative system, but you can do administrative, clinical, or joint administrative clinical. It's a great way, and we don't have time to talk about it now.